Good morning. I think we need to start because I know the first day normally people are coming at 10 and on 9 onwards. They will find us already, but we have to start with a word of prayer. So let's bow and pray for the day. And shall we believe? Even as we pray, we should know that this is what is required of us, and we do so with joy. So let's pray. Father, in the name of Jesus, the Son of Nazareth, the Father of all, the head of the Church Universal, we are thanking you this morning, even as we start our meeting, and we are saying that the wisdom that comes from above is what undertakes all activities of the God of Standards. We are thanking you for the nation of Kenya. We are thanking you also for the executives, beginning with His Excellency the President and all our executive members in Kenya and members of Parliament. We're also thanking you for the institution where we are, the Nutrition Fraternity, and all our families, for you have maintained and kept your promise for good health. Now that we want to start our meeting, we are asking for the spirit of excellence, divine wisdom, and divine direction, that we may demonstrate the wisdom from above through our expertise that you yourself has deposited in us. As we do this throughout the day, we ask for your presence. We ask for your guidance in the name of God the Father, God the Son, and God the Holy Spirit. Amen. So, welcome everybody. Professor was to chair this session. Professor Nguka is just somewhere around here. We acknowledge that this place could be far sometimes. And I want to say something before that. We had indicated yesterday when we were opening the conference that the conference will officially begin at 8 today. And going by the program which we have, we are already a bit late. So we will be late with 1 hour. But as the process runs, we will recover. So today we are starting with a side event, which is going to come from SAN, CSA, and together with the ICASA. And this is on breaking barriers. The focus is on gender, transformative approaches, and how it affects or strengthens the nutrition outcomes in Kenyan health system. I'm just paraphrasing. I think the presenter will give the exact title. So we are here with SAN team. Maybe if you are in can you wave? I know Koth is here to lead the presentation, but we also have you are all divided. One is sitting there, another one. Oh, we are networking. So Edgar, I think it's your time. We will be allowing people to walk in quietly. The instruments we are using are very sensitive, so they just sit and then we listen to the presentation. So karibu.
Yeah, thank you so much, Daktari. And as I said yesterday, I'm always delighted to work closely with you. Noja tumetoka mbali. Yes. So just as you've said, the side event that we're having today is to look at how gender is contributing to nutrition outcomes. But before then, it's always good that we introduce who we are, because I'm not sure all the people in the room understand who SAN is. Because whenever I always try to introduce SAN, people always think that I'm talking about the normal jua, the sun that we all know about. So I'm going to introduce who we are and what we do and where we do it and how we do it. And then thereafter, I'm going to recruit quite a number of people to also join the Sun movement. So my introduction is going to include Sun movement at the global level, at the regional level, and also at country level. So by name, I'm Edgar Okoth, the Executive Director at Sun CSA here in Kenya. But I also double up as the chair of the East and Southern Africa, Sun CSN. Yeah, so I'm going to introduce all that. So Laura was supposed to make my slides appear. Yes, so that you follow through what I'm going to talk about. But just to let you know that the architecture of today is that once I've introduced who we are, then Margaret is going to come here, and then we're going to have a panel discussion highlighting what and how gender contributes to nutrition outcomes, better nutrition outcomes. And we have a diverse panelists coming from the county, from the civil society, but also from research institutions. Okay, I'm just going to talk through it. So SUN, it's an abbreviation, and it means scaling up nutrition. So this is a global movement, but with country priorities. So it's a movement of the willing, and countries join the movement once they see fit that it's something that they would want to be part of. SUN was established in the year 2010. Oh, great. Yeah, so just put it in presentation mode. Yeah, so whenever you see that logo, and yes, it has the demonstrations of the rays of the sun. So that's where we derive our logo from, because it illuminates countries, and we would want to ensure that we are scaling up nutrition. And it has three really strong words: engage, inspire, and invest. And these are the things that we've been doing in nutrition for quite a long time, in terms of ensuring that we're having multi-sectoral collaboration, but also multi-sectoral engagement. We inspire in terms of the things that we do so that we can have other people also do it. Invest in terms of having both global investments or bilateral investments, and also having domestic investments into nutrition, because we believe that that is what will ensure that we have sustainability. SUN, as I said, it's a movement, and the uniqueness that it has is that all people have the right to food and good nutrition. And even here in Kenya, we've been talking about the right to food, and also ensuring that everyone has got good nutrition. And that's why I believe we are here in terms of enhancing the nutritional status. Next. Next slide. Yes. So currently, we have 67 countries that have subscribed to SUN. And as I said earlier, is that SUN was established in the year 2010. Kenya joined SUN in 2011. And during that time, we had Madam Terry Wefafwa that led us into joining the SUN movement. We all know, and it's something that has been discussed over and over again, the complexities around the issues of malnutrition. And whenever there are complexities around issues to do with the malnutrition, it means that we have to work together, and that's where the issues of collaboration and coordination comes in. There is something that we say in the Sun movement that is really, really, it leaves always a mark in me, leaving egos and logos behind. Yeah? I don't know whether that really means something to you. When you leave egos and logos behind. Whenever we do our programming, whenever we write our proposals, whenever we do our collaboration, we always have the logos. And as you can see here, we have the KNDI logo here. And also, even for us, we have our logos. And also the egos that we do in terms of our programming. This is my turf, you know. Why are you coming to implement where I am implementing, you know? And even if you go to the counties, they'll tell you, this sub-county, it's for this particular organization. Can you go somewhere else? Yes. Karibu sana, Prof. Yes. And for us, we say that for us to be able to make any meaningful impact in our programming, we must leave our egos and logos behind and work as one. Whenever we do that, then we will jointly be able to engage and properly make an impact that we need in our societies. Next. So Sun works through approaches, and for us at global, and this is something that we also cascade at country level. We have 7 approaches that that really define what we do. I'm not going to explain all of them. So one is health and well-being. Yeah. So whenever we do our interventions, we ensure that they really align very well with the health. The second one is WASH, water sanitation and hygiene, because we know the importance factors that WASH does. Gender equality, and we are going to discuss much more on that in terms of how gender also contributes to issues to do with malnutrition, and also in terms of improving the nutritional status of the society. And when we talk about gender, we're not just talking about the female. And many times when people talk about gender, then we have this propensity to look at, okay, fine, so why are women not in the room? Yeah, so gender actually talks about both sexes. So it's something that we're also going to expound much more in this side event. And then planet. The planetary health is something that we are getting more and more evidence that if we ensure that our planet is healthy, then it has a direct contribution or a direct bearing to our nutritional status. Then education, that is really something that we ensure that we improve education both at pre-primary, primary, but also at tertiary level. And then prosperity, economic prosperity is something. You remember I talked about investment. Yes, so whenever we have investment in nutrition, it leads to economic prosperity, because we say one of the malnutrition outcomes is stunting, and stunting is both a marker and maker of development, and it contributes directly to prosperity. Peace, yeah? We know where we have conflict, we have high levels of malnutrition. So we always want to ensure that we promote peace, but also people fight over food, you know, and they're saying that food is going to be the next frontier of war. And we are seeing food and nutrition being used as a weapon. Yeah. People now are not using guns. Yeah. They're now using food. Yeah. When they deny soldiers food, then you starve, and then you're not able to. So we ensure that at least there's peace, because then in a peaceful society, then that is a society that is well nourished, because then if you're well nourished, why are you fighting? Yes. Yeah. So also we have programs that we do in terms of the fragile states, and also states that are not. Yeah. So when you look at the architecture of how Sun works, remember I said Sun is a global movement, but really it has country priorities. So out of the 67 countries that have already subscribed to Sun, they have their priorities. So the priorities are not set at global level. Priorities are set at country level. And that's why different countries are at different levels. So when you look at the country level, we have a multi-stakeholder platform that brings all the stakeholders together. So SAN works through networks. And at global level, we have 4 networks. At country level, we have between 4 to 7 networks. Kenya, I think, is the one that has got the highest number of networks at 7. So the 7 networks that we have in Kenya is one, the government network. Let me start with government, because the government brings us all together into one platform. And the government network, the lead is someone we call the SAN focal point. So the SAN focal point is the leader of the SAN movement in Kenya. And then we have the civil society network that I have the privilege of coordinating. We have the donor network that also brings donors that work within the food systems and nutrition security space. We have the academia and research that help us in terms of generating evidence that we need. We have the UN that brings all the Rome-based organizations into one platform in terms of how they're able to engage. We have the business network that brings the private sectors together to be able to engage on issues to do with nutrition. And then we have the youth network. So the youth network also is our newest kid on the block, and they say nothing for us without I nothing for us without us. Yes, so the youth, that is one of the mantra that they say. If you want to engage us, if you want to ensure that you know what really we want, then you must bring us on the fold. And that's why we have the youth network also helping us in terms of how then do we be able to identify what really the youth need. Next. Yeah, so our major goal as a movement is to end malnutrition by the year 2030. It's very ambitious. It was very ambitious. We have 5 years to go. And yeah, we've kept on asking ourselves, yeah, can we do it in 5 years? Can we do it in 5 years? Last year, we turned on, yeah, all our engines to ensure that that is done by the year 2030. So we are still very positive that it's going to happen. However, statistics tell us something different in terms of the number of countries that are moving towards that. Kenya was moving towards that in some indicators, but then we have since gotten back to where other countries are. But we are still hopeful. Things can still happen. We hope that people and companies and countries will be able to invest so that we end malnutrition by the year 2030. We are still crossing our fingers. Yeah, so that is our overarching goal, to ensure that that actually happens. And we want to do this using these 5 major approaches. One is raising awareness and advocating and campaigning. Yeah, so one of the things that I'm doing right now is raising awareness, and what we're going to do here for the next 4 years, 4 days, is to raise awareness, generating evidence. So a lot of evidence that has been generated will be presented here today, and we'll see, can they help us in terms of ending malnutrition by 2030, mobilizing resources. So that is something that we do in terms of the work that we do, both domestic resources, but also looking at globally and also from the private sector to see how best can that happen, creating learning opportunities. So this as one, and that's why when I was talking to Daktari in terms of how can we engage with KNDI to be able to have learning opportunities. Scientific conferences are learning opportunities for us to know what is it that is happening, what is it that we can take to scale, what is it that is not working. I'm here to see where someone is going to present something that, you know what, we did this, but it doesn't work. It's also a learning. Yeah. So, Daktari, I hope you'll allow that. I hope there's an abstract of someone who said that this does not work. Yes, let's try it the other way around. It's also a learning opportunity in terms of what is it that doesn't work. And then also promoting solutions and amplifying the voices of the civil societies We know the role of the civil societies. Our work is not just to oppose, but we also support, and we also collaborate. Yeah, our work is not just to carry placards and cry all the time haki yetu. Yeah, it's a good one, but we also work in terms of how then do we also provide solutions. And then governance. Governance here is really critical in terms of it demonstrates what really can we move. Bad governance leads to poor nutrition interventions. Siasa mbaya, maisha mbaya. Yes, those who lived those days, and we thought that it was a lie. So siasa mbaya, maisha mbaya. So if you have bad governance, I'm not saying that I'm equating governance to siasa, but it's part of it. Yeah. So it's how now we bring a good governance in place. So also we work a lot in terms of looking at the governance, both within the civil society alliances, but also in terms of how then do we improve governance in terms of system strengthening outside the civil societies into government. Next. Yeah, so for us at the regional level, yeah, so what I was talking about is the global. Yes. So at the regional level, we've highlighted 5 critical things that we believe if we implement, then we will move the needle towards ensuring that we end malnutrition by the year 2030. So these are the 5 for that one. One is wasting agenda. And the reason why we chose wasting agenda is it's one of these neglected malnutrition outcomes, because many countries will always work on the stunting, because they believe that stunting is what will, if you reduce stunting, then there will be economic development. But we believe that, and we know science has proven it, in terms of the number of times that a child is wasted, then they'll automatically become stunted. So that's why we are picking that, and we're providing a platform for members, but also stakeholders, to be able to engage and come up with solutions to see how best do we ensure that we reduce wasting. And then the second aspect is in terms of legislation. Yeah, I know whenever we talk about working with parliamentarians, both at national level but also at county level, then people shy away. Yeah, and they give them names, but we like it or not, these are really nice guys. Yes, if you know to speak their language, yeah, they're really nice guys. And once they have understood exactly what you're talking about, then they're able to provide solutions. They have a lot of solutions that, as much as we share away, but we have to engage with them. So at the National Assembly, we have established a parliamentary caucus for food security and nutrition. And this caucus brings over 130 members of parliament drawn from National Assembly and Senate. And the beautiful thing about the caucuses is that it's always for the willing. So it's not a committee whereby you have to attend it to be able to perform your function. But then when you have 130 members of parliament who see the benefit of having a conversation around nutrition, then making legislation, making policies, and also ensuring that accountability in parliament is done, something that we've worked with them on. They're quite, I think there are now 3 pieces of legislation that are in parliament at different levels, focusing on nutrition. The act on KNDI is because of parliament. Yes, if they didn't see the need of having that, then we wouldn't be having KNDI right now. The third aspect that we're working on is in terms of having champions. We cannot be present everywhere. We need people to help us tell our story. We need people who believe that nutrition works. We need people who can talk on our behalf, because different stakeholders have different people that they trust. Yeah, so for us, we identify such individuals, we build their capacity, and then we deploy them in terms of going to discuss issues to do with nutrition. So we have champions that have been drawn from the community level, from the county level to the national level. So then the pool of champions discuss issues to do with nutrition in the language that they understand. We've always been accused of talking to ourselves. Yeah, when I talk with Prof here, sometimes you will not understand what we're talking about because we'll use these jargons, we'll use all these things. But then when you have a county assembly member, a speaker of the county assembly, talking about nutrition in a language that they understand, then they are able to sway the members of county assembly to be able to invest in nutrition. When you have the county first ladies, because they are also our greatest champions, they discuss issues to do with nutrition in a language that the community members can understand, a way that I will not be able to bring out these issues. If you have someone in the media talking about nutrition in a media language, yeah, then we find that we have a better understanding of nutrition holistically. And then the fourth aspect that we believe will help us achieve our goal is having policy. Yeah, and for a very long time, we've always engaged on issues of nutrition, but we know how government plans. Government, if it's not in a policy, it means that it is not the intention of government. Yes. So government always puts their intentions in policies. And that's why we are saying that for nutrition also, it has to be in a policy. Yeah? And then the last aspect of it is in terms of capacity building. And capacity building here, we look at it at two levels. That is the technical capacity, so that we train people to understand the technical aspect of nutrition. And then the second aspect of it is in terms of the institutional level. And the institutional level here is that you understand in terms of how does leadership enhance implementation of nutrition. How does systems, because if you do not have systems to deliver, then you will be doing a lot of injustice and you'll be doing more harm. So we do both in terms of technical capacity, but also in terms of institutional capacity, because that is what will help us on issues of accountability, because accountability also goes a very long way in terms of enhancing implementation of nutrition. Next. Yes, so I'm not going to explain. So this is just our regions that we work in. Next. Yeah, so also we have partnership between us, because then we're saying that we cannot do this alone. Partnership within the region helps in terms of the region economic blocks that we have. So we have a very strong partnership with the East Central and Southern Africa Health Community. So this is a regional economic community, and it's an intergovernmental that brings all the health ministers from 22 countries together. And we are privileged to be meeting them. Yeah, so we meet them every year to discuss issues to do with nutrition, to discuss issues of how do they invest in nutrition. Because after these meetings, we are seeing incremental perspective, we are seeing incremental investments in nutrition. So that's why we are saying such partnerships are really critical in terms of enhancing whatever we are doing within Kenya, but also across the region. Next. I think just, I'm not going to go through that, what that means. Just go next. Yes. So when you look at the things that we want to achieve in this partnership is harmonize regional nutrition frameworks and guidelines, and that is something that is in the works. Increase domestic and regional financing for nutrition. So issues to do with financing will keep on coming up over and over again, because without proper investment, without sustainable and climate smart investments, then we will not be able to reach our goal. And then strengthen multi-sectoral coordination platforms, because again, you remember what I talked about, leadership. Leadership really plays a lot in terms of bringing people together, but also in terms of enhancing implementation of nutrition interventions, enhanced accountability and evidence-based decision. And there's a time I was having an engagement with the Isiolo County Assembly, and I was talking to them about issues with nutrition, and they asked me, who told you so? Yes. Yes, who told you so? So until I had produced evidence in terms of, if you invest $1, you have a return of $22. And we had to break that down, and we had to provide evidence from Kenya. Yeah, when we did the cost of hunger study, that really provided us with the evidence that we needed to be able to really build a case. And from that on, they invested 100 million Kenya shillings into nutrition. Yeah, so that's how strong evidence is, yeah, in terms of decision making. And many of us, we are going to present evidence for us to inform our decision. Most of the things that are going to be presented here are based on evidence. And then also the last one is improved nutrition indicators and public health outcomes. So we know in terms of whatever we're working towards is in terms of how then do we improve our nutrition outcomes. Next. So the focus areas, I think I've talked about this: multi-sectoral collaboration, policy influence and advocacy, and capacity strengthening for nutrition. Next. Kindly tell me if I'm going beyond time. Yeah. Because I can always talk and talk. Yeah, so I'm not going to talk about the objectives. Let's just skip all the objectives. Yeah, let's just move to the next. Yes, so the thing that we are saying within the East and Southern Africa, Kenya included, is that we must come together. We must come together in terms of strengthening our knowledge, but also in terms of pooling our resources. If we cannot strengthen our knowledge, but also pool our resources, then we are not going to make it. Yeah. The 2030 is going to pass and we'll be where we are. Yeah, so it's about time we came together in terms of strengthening our knowledge. Knowledge is power. And if you do not have knowledge, then you don't know where you are going. And also in terms of the resources that we need, both the resources at the community level, because it's about time this also start in terms of how do we also utilize the resources at the community level to be able to engage. Next. Yeah, so coordination will also be there in terms of having a nutrition expert committee to be able to inform us on what needs to be done at what particular point. So next. Next, I don't want to go to the roles. Yes, so through this, we have some commitments that will help us in terms of ensuring, and these are the things that we'll be monitoring as we get to the year 2030. One is a partnership in terms of pulling ourselves together so that we can synergize our capacities. And already we have quite a number of members who are already seeing the sense of us having. So the RBO is the Rome-based organizations. Within within nutrition, we have a lot of acronyms. Yeah, so you'll bear with me today. So the second one as a commitment is enhanced accountability. And the accountability here that we're talking about is the mutual accountability. That is accountability amongst ourselves. So we must hold ourselves accountable first before we go out there and hold other people accountable. So we are going to do the mutual accountability amongst ourselves, but also hold other stakeholders accountable. Mobilize sustainable financing. And what we're looking at in terms of sustainable financing is both domestic. And the domestic financing that we're talking about is the community resources. So that's what we're going to go for. And also in terms of the government resources from the exchequer, but also external resources that have been around for a long time. And we're seeing that really dwindling. So it becomes number two in terms of what we're going to look at in terms of sustainable resources. So, and then we have promoting knowledge management, and we'll see research innovations and also implementation models, those that work and those that do not work. Yeah. So let's be bold enough to be able to also share those innovations, but also implementation models that do not work. Ladies and gentlemen, we have 5 years to go. Yeah? We want to eradicate. Yes, people are saying, you know. Yes. Yeah? We have 5 years to go. Yes. And if we do not share things that do not work, we'll keep on building evidence around it. Yeah. So tell us these things that do not work so that we can move on. You know? Yes. Let us, researchers who are here, tell us these things that do not work so that we don't waste a lot of resources and a lot of time in it. We'll say this one does not work. We've learned from it. What is the next thing? What can we scale? Yeah, so that's why for us, this, and actually we are here and we're going to be with you, yes, for quite a long, long time, because we want to build this, because there's a lot of potential in terms of just sharing information, sharing research, sharing models that work and those that do not work. Next. Yeah, so that was about our global and our regional. So let's come to Kenya. And Kenya, I'm going to take 3 minutes. Yes, very quickly. Yes. So in Kenya, we also have the civil society network, and it's called the Scaling Up Nutrition Civil Society Alliance Kenya. And it was established in 2013, just after Kenya joined. And we are based in IHIT, so it's a national organization. And CSA has a membership of 423 members. So we are an organization of organizations. Yes. So the 423 members are drawn from international organizations, national organizations, community-based organizations, women-led organizations, youth-led organizations, all working towards ensuring that we eradicate malnutrition here in Kenya. So this is very specific to Kenya. Next. Yeah, so we have a vision, we have a mission like all other organizations. Next. We also have got a mandate, and our mandate are 5. One is to mobilize and also coordinate in terms of working to build capacities, and I'd explain the issues with capacity. We work in policy, because that's also something that we do very well. We inform the general populace, or the general public, on issues of nutrition and also matters of social accountability. We work on the nutrition agenda just like our global and regional colleagues. And then we also part of the global movement. And that helps us in terms of transferring knowledge from Kenya to global, but also drawing global best practices to see how best we can also implement that. Next. Yeah, so our core values: 1, good governance, integrity, innovation and creativity, equity and justice, partnership, but also ensuring that there is holistic participation. So those are really critical for us, and we hold them dear to ensure that our work is done well. Next. Yeah, so in terms of our approach, our approach is on advocacy. And when talking about advocacy, we do both policy advocacy and we also do budget advocacy, because we understand how policy is critical. We also understand how budget is critical. So that's our level of engagement on those 2 aspects. And then learning, communication, and information sharing. So we use a lot of platforms in terms of engagement of our stakeholders, but also in terms of bringing in the communities, and also institutional strengthening and development. Remember, I talked about in terms of technical capacity, but also in terms of institutional strengthening, because we understand if you do not have a strong institution, then delivery of nutrition services becomes something that is dire. Next. Yeah, so like all organizations, we also coordinated. Remember, we cannot go out there to talk about coordination and good leadership if we do not have good leadership. So this is our structure in terms of how it's coordinated. So we have the 423 members at the apex, and they're the ones who make the decision. So if they say I get fired, I cannot fight with them. They have said, yeah, but they've been good to me because I've also been good to them. Then we have the board, the executive committee, and then we have the secretariat, and then under that we have the committees. So yeah, so just go to the next one. Next. Yes. Yeah. So this is how the board structure is: the chairperson, the vice chairperson, the executive secretary, the treasurer, and also members of the board. So these board members are drawn from the membership. So there's an election, and members are elected. Yeah. So we have the chairperson is Nutrition International, led by Dr. Martha. The vice chairperson is Collaboration of Women in Development, Miss Betty Sharon. And then I'm the executive secretary, and then treasurer from GAIN. And then we have, so this will need to be updated. Then we have board member DSW, World Vision, Feed the Children, Concern Worldwide, ACF, Feed the Hungry, and Hamrep Health Africa. So these make our board members that provide strategic direction on what we do and what we don't need to do. Next. I think we're coming to the end. So currently we are implementing 3 projects that are being implemented in different parts of the country. Next. So some of the achievements that we've had is in terms of policy advocacy and influence, and we've worked on quite a number of policy frameworks, but also in terms of just implementation documents that help implementing nutrition in the country, improve coordination at all levels. So we are engaging at all levels, including engagement with the Office of the President to ensure how best can we elevate issues to do with nutrition, so that it becomes truly a multi-sectoral thing, not just within one sector. We are also working with Council of Governors and also County Assembly forums to ensure that nutrition is actually enshrined in their day-to-day working. We are having quite a number of policy dialogues at national, but also at community levels. Next. Yes, in terms of issues to do with resourcing, this is something that is also dear to us, and we are doing a lot of roundtables. Yes, so roundtables so that we have a small clique of people to understand their language, and we talk to them, why do you need to invest in nutrition? So those roundtables are really proving to be very effective. Yeah, especially if you're having policymakers, if you're having people who are in charge of budgets, and their peers, then someone will say, okay, fine, I think nutrition deserves 10% of our budget. The other one will say, no, 10% is too little. Let's push it to 15%. Yes. And some are saying, no, we're going to give you X amount. And we're seeing that really making it very effective. We're also supporting in terms of planning on issues to do with symposia, because then we believe that with that information, we generate a lot of evidence. And then advocacy at national and county level. So we believe that with structured engagement, it makes a lot of impact. So we already have an MOU with the county first ladies. We also have an engagement with the women parliamentarians that is also ongoing, but also at the National Assembly, we also have got the Parliamentary Caucus for Food Security and Nutrition that also enables us to be able to conduct proper advocacy. Next. Yeah, so media are also critical to us, as much as many times when a media personnel approaches some of us, we shy away. Yeah, because we also understand that they also have got their agenda. But what we've done is that we've mobilized them and we have trained them to understand issues to do with nutrition and how they can become our allies. So we are engaging with them on a regular basis so that information that goes out is the right information, is the accurate information, so that they also help us in terms of issues to do with mobilization. So for us, media are our friends. Yeah, that's why we are not media shy. That's why any of my staff is free to speak to the media. I know, Dr. that might not be the same here and in many government institutions, but we've made media be our friends because we understand, and they have now also started to understand issues to do with nutrition and food systems and how they can come in terms of combating misinformation, but also in terms of helping mobilize the communities. Next. Yes, so we're also working with the Ministry of Health and helping champion issues of new products. So we are currently chairing the National Task Force for multiple micronutrient supplement. So this is a supplement that will help in terms of combating issues to do with anemia, but also in terms of having good birth outcomes. And we are working to help the country introduce such product here in Kenya. So that's one of the things that we believe that we are helping in terms of high level advocacy. Next. Yeah, so these are just some of the things that we are doing both at national, at county, but also at the community level to help champion issues with the nutrition. Next. Yes, and I think that's it. I hope it wasn't too much information overload. But Dr. allow me, just go to the first slide. There's something that we normally do in all our engagements, whereby we want to have as many people be part of this Yeah, just the first slide where we have our social media. Yes. So we would like all of us, yeah. I think this is the only time we allow people to have phones. Kindly, just go to our page and subscribe. Yes. Yeah. Just go to our page and subscribe. So, Daktari, as they subscribe, I want to thank you so much for this opportunity, and I hand it back to you. Yes. Oh, yes. Oh, yeah, you've reminded me. Yeah, so I'd like to take this opportunity because remember, I talked about us pulling our resources together, but also coming together to engage. And we recently signed an MOU with the KNDI because we believe that KNDI provides a very vital platform to engage. Being a regulator, we believe that working with you is something that will help us achieve our agenda, but also achieve the agenda of nutrition in general. And one of the outcomes is now us participating in this forum, because this forum brings people together, but we are also able to disseminate information. We are able to disseminate evidence. For us as civil society, we cannot work without evidence. Yes, because someone will ask you, who told you so? And I'll say, no, 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 no. I came to this conference and it was presented, and it is data that is here in Kenya. Secondly, this working with you, Daktari, will enhance in terms of participation of other stakeholders. Already I'm getting good vibes. Yes, you're working with KNDI. Now that is something that we must be part of. Yes, and very soon you will see people coming to this office wanting to know, what does KNDI do? How is this going to work? And I believe that that MOU is going to catapult us to the next level of our engagement. And even within the East and Southern Africa, people have started asking, how did you manage? How do you work with the regulator? Regulators are not bad people. Yes, yes. I know there are things that you need to police, but for us, we believe that collaboration is something that is going to work. So kindly note that we have that MOU and it is working. It's already having ripples, and we believe that as we move along, then there are good things, there are good tidings that are going to come out of this MOU, because KNDI is a huge organization. SANCS is a huge organization. So we're bringing people together in terms of championing and building the roadmap of what needs to happen. Yeah, thank you so much, Dr. Yes, yeah.
Once again, can we have some hearty claps for Edgar Okoth? I think, to be honest, the first time it's Professor Nguka who bridged you and us, because you looked at us from the police side, and then we now became friends. And KNDI is an organization created by an act of parliament with two roles, that is regulatory and service. That is the only difference between us and the Medical and Practitioners Board. And also, you know very well that the service arm is targeting the Kenyan population. So we are going to work with both governments, the national government and the county government. And you are welcome. So I want to take this opportunity, first of all, to welcome our guests, everybody, because some of us were not in the opening remarks yesterday and the opening session. It was very wonderful. Food remained because you were not present. And the chair was not there, he was on transit, so they delayed. I want to introduce the chair of this conference, that is Professor Gordon Nguka, so that after this he can take over. Professor Nguka is the chair of the conference and also the incoming chair for the Kenya Nutritionists and Dietitians Institute. We are only waiting for gazettement. I think the last time I talked to Honorable Dwale, he said that this is going to be done not later than next week. So we want to welcome you, sir, and we want you to take over the conference. It's still the chair of artery programs, that is the service wing, and he has been a member of the council for quite some time. I think he's the longest serving now as a member, but if he comes in as a chair, that will be good. He has great passion for nutrition, and we initiated the GND together with him. That is the Journal of Nutrition and Dietetics. So, Prof, you can come and take over, then we go to the next session. And as you take over, you know what we normally do for the summary. Yeah.
Thank you very much, Dr. K. Edgar, I'm happy. When I see you here, I'm excited. Now I know nutrition is in the right direction. Ladies and gentlemen, good morning. I want to appreciate all of you. I should have been here yesterday, but due to some unavoidable circumstances, I wasn't able to be present, but I was spiritually present with you. We kept on communicating with the CEO and making sure that those who were here were well taken care of. And I believe, I'm just told that you people left food. Some people are not in. So I want to appreciate all of you for being here for our 5th conference at JND. Edgar, you have done very beautiful presentation, and I'm surprised. I never knew that SAN was already organized and very structured in that manner. Now today I have a different aspect of SAN, and I'm excited because I was fully informed of the processes, especially when the MOU was being signed, and we endorsed it fully, both from our research perspective and even as KNDI. I was able to talk with our outgoing chair, and you can be sure you're fully accepted, and we are going to work together moving forward. You have made very important presentation here, and especially the SAN Global, SAN Regional, and SAN National. And there are very clear flows in terms of operations that I think we are going to harness. I'm very excited in terms of, acting locally, but with global thinking. And I think that is one of the strengths that SAN is bringing on board. Bringing global ideas to local action actually enhances, it could actually fast track. Within 5 years, you might just be able to, I'm not very sure whether you'll eradicate, but but I'm very optimistic that there will be some movement. And taking into the talks of Martin Luther King's, that if you can't fly, I'll just paraphrase. If you can't fly, then walk or drive on the ground. Let me just paraphrase. And if you can't drive, please walk. If you can't walk, crawl. But by all means, make sure you're able to. So even if it is 0 point, so long as it is positive deviation, I think we'll be very grateful. So let's aim high. Yes, do eradicate. But even if we don't eradicate, so long as there is some positive deviation, we'll be very happy, isn't it? And I think that is exactly what you're doing. I want to do a summary. You have brought in a lot of things, especially on the regional part, where you have about 5 pillars which you are implementing. And one of them is capacity building. And in your presentation, there was a talk about institutional capacity, technical capacity, and also system-wide capacity, I believe. One very important capacity was glaringly lacking. I don't know. How do you deal with community capacity? That's the only one I didn't see. I would like to know, because in your structure of thinking globally and acting locally, community capacity forms one of the lowest part of it, and I think should be one of the action area in terms of linking all that to community. I don't know whether it is part of your overall structure, but it is the only one that I didn't see. All others capacities were very well presented there. And in terms of summary, I would like to appreciate in terms of your action lines, the activities scheduled, and enhancing capacities accordingly. And Dr. Kea, I would like to, in short, appreciate the SUN movement and especially for our work to be able. So that one I've posed as a question. Maybe Edgar will answer that component so that we can be able to, ensure that the communities are actually involved. Since you've said there is nothing for us without us. I think that's the spirit. So there is nothing for the community without the community. Thank you very much. So in the next order of events, immediately after the SUN Symposium, is our keynote address. So, Dr. Kea, I will introduce you, but if you allow me, I just want to allow, if Edgar can address that issue of community, then, yeah.
Thank you so much, Prof. And it's something that comes up every other time we make this presentation. And it's good to note that as SUN, we do not directly implement. Remember, we have membership. Yes, so our members within the East and Southern Africa, we have over 4,500 members. In Kenya, we have 423 members. And remember, I actually explained international, national, community-based, faith-based, youth-led. And so they actually do the capacities and they do the implementation. So during their interventions, then they build the capacities of the communities. Yeah, so for us, we only come in now during the social accountability. So it's not forgotten because we do not want to have conflict with our members, because then again, if we have competition, then they'll ask, why are we being part of SUN? Yes, so we do the things that they cannot do. So we provide that level of platform. Then with them now, they interface a lot with the communities. But we also get feedback, and it also feeds into what we do in terms of our system strengthening. So it's not forgotten. It's handled by our many members who interact directly with the communities. And as you can see, even my members of staff, we are not many. Yes, in the office, we are just 7 of us working in all the 47 counties. But the 423 members are able to do the implementation. So we don't do directly implement, our members do, and they do the capacity strengthening at the community level. Yes, Prof, if you allow me, yeah, so let me have the staff. Maggie, Charlene, Dama. Yes, so you can see they're also very beautiful, eh? Yes, yeah. Yes, they're eating nutritiously, eh? Yes, yeah. So Margaret here is in charge of programs. So anything to do with the programs, she understands. She's my boss. So I don't do anything. She tells me what needs to be done on the program side and whether we have money or not. And then Damaris is in charge of external engagement and also engagement with stakeholders. So I know you'll be interacting with her a lot, and she'll be recruiting quite a number of you and telling you more about what we do. And then Charlene takes care of our communications, our social media, but also she's also in charge of a new project that has just come in for the Micronutrient Forum. So she's also very technical when it comes to this. So Dr. will also be interacting a lot with Charlene in terms of how we do most of this technical. So I have 2 more other staff, but they are on the admin side of it. So they were not able to come here today, but they'll be joining us on Wednesday, because I always want all my staff to have a feel of what we do, so that they also appreciate the vision that we have and how we can advance that vision. Yes, and we also needed to have a panel. Yes, so talk to. Yes, we're going to have that. Okay, thank you so much.
Thank you.
Okay.
Edgar, I think today I'm answered properly. Martha, I thought Martha was here. She'll be coming, huh? Okay. For the first time, I want to believe that we have now brought on board everybody who are actually necessary for implementing Matters Nutrition. It is something, what is itching your minds has been itching our minds very strongly. And we have been on this game. One of the key areas you've talked about is health and well-being. Go down to the deep history. Who developed health and well-being? It's actually us. We developed health and well-being since 2009, before it became a sustainable goal in 2015. And we have been itching ourselves whether we will be able to meet this aspect of eradicating nutrition. But I'm happy San has taken it head on. And now that you are with us, let's see how we are going to lead this process together. Thank you very much. Let me now take this opportunity to welcome our first keynote, Dr. David Okeyo, who has over 15 years of experience in public health nutrition research, as evidenced by over 45 peer-reviewed publications spanning from the year 2007 to date. Dr. David Okeyo is currently the editor-in-chief of J&D, and he has assumed various positions in the various government and regional appointments. He was among the team appointed in the membership of the Secretariat for the Intersectoral Committee on Health Workforce, Education and Training Reforms. And I want to expound on that. In our role as a regulator, we work with other regulators in the country, in the Ministry of Health. And in that, we have spearheaded harmonization of training. And especially for the nutritionists, there have been a number of areas that nutritionists have been restricted. But we are telling nutritionists, don't be restricted, especially for parenteral nutrition. Nutritionists have been running away from this issue of putting just a cannula online. And we're asking them, why are you refusing to put a cannula? Yet this is being done by somebody, even by themselves. We have individuals who put cannulas on themselves. You know that. So we have been trying to have a common curriculum, even for nutritionists to be able to diagnose, for example, death. Isn't it? Yes, you should be able to certify death. So this process, that is being headed by Dr. Okeyo here at the national level under the Ministry of Health. And he has been serving on that to bring reforms in curricula and harmonization of curricula, spearheaded by the Ministry of Health under the Ministry of Health Act 2017. In July 2022, he joined membership of the Infant and Young Child Committee within the breast milk substitute regulation and control of, under the Act 2012. As at we talk, Dr. Okeyo is the chief of party that spearhead the implementation of Kenya Nutritionist and Dietetics Institute Resource Mobilization Hub in the name of KNDI ATRI that has organized even this conference. He serves as the chief executive officer of KNDI that all of us are aware of. And you know the role of KNDI, especially on the aspects of regulation, of practice, and even training. He has previously served and worked as a head of department at Maseno University. And is a leading consultant in matters monitoring and evaluation in very many programs which he has served in. And he had previous experience with the East, Central, and Southern Africa, which I've seen Edgar present. You were working with EXA, East Africa, and which we have consulted with before. And Dr. Okeyo, I did a joint curriculum. I spearheaded the development of the frontline health workers curriculum for nutrition. And Dr. Okeyo is the one disseminated it. We developed it under World Bank, and I was the lead consultant for that. Then Dr. Keo picked it over and disseminated it across Africa. So you need to know that we have a curriculum. There's, I don't know who is aware that we have a curriculum that was developed for the East and Central Africa. Common curriculum for nutrition. It's online, you can Google. It's for frontline health workers. We decided to control who is to do what. When it comes to matters nutrition, we said we released about 12 units for common, so that doctors, nurses, and everybody else can do up to that level, beyond which we expect the issues to be transferred to the professionals accordingly. So in that, Dr. Keo disseminated that. Apart from that, he has worked and continue to work in many other areas, especially the food security and nutrition programs. His dream is to facilitate work environment characterized by strong programming and research that informs broader audience through harmonized, high quality, shareable publications on nutrition issues at community, national, regional levels, and even global. And this is basically to enhance well-established human capital management. That is Dr. Keo. And you can see we share all the dreams in this, including the Sun movement. Let me now take this opportunity to welcome the first keynote, Dr. David Okeo, the CEO for KNDI.
Prof. Thank you very much. I want to, first of all, talk about the fact that we also have some of our guest speakers who are keynotes in the house. Joanne, and your team, Christine, you feel welcome. We also have some online. So this is Kendi, I feel at home. And it is a home of green and gold. So we are very happy to have you here and our professionals who have just arrived. Privileged to have the first keynote. Before that, I would want to say that when you see the GND origin, just one statement. From a university background, one thing I asked Professor in 2014 is that if you're pushing me to go and become the first CEO of nutritionists and dietitians, and with an act where there are no structures, am I not going to lose my mind with the research? So what am I going to do when it comes to the passion of research? And he told me, you just go. And we can even initiate a journal. And you remember the first time in 2016, it was resisted that a regulator cannot have a journal of nutrition and dietetics peer reviewed. And we pushed it to 2017, and 2018 we launched the first journal. In 2018 we had GND, no indexing, but then after that we started the indexing process, and we came up with the editorial board. So Professor and I are in the board. We have other 4 members of GND. And the journal has run a series of conferences. This is the 5th in the series. So we have indexed now with the AJO, that is African Journals Online, and we are also cross-reft. We are both print and online, electronic. And very soon we are completing the process for Scopus. So then the journal becomes a platform for African nutrition science. We also allow for international publications. So feel welcome, and I will give the first keynote. I know that there are members of the 4th estate in the house. Very interesting. Edgar, you said we need to have media on board. This is a place of media. And Kenya cannot run without media. So the members of the 4th estate in the house, I think is KBC, correct? Is Cheriot there? Oh, Cheriot. So this man, Cheriot, has lived with KNDI from 2009 to date and is a media mobilizer. Sometimes I'm asked, where do you get the money to be on media all the times? Don't worry. So we shall be there together for both county. Good. So I want to believe that I'm between you and your team. And so I will not spend more than 1 hour out of this. But I have a keynote that is a bit different. It's not the academic research, but it is focusing more on professionalism. And when we talk of professionalism, we are talking about the person in charge of nutrition service delivery. And so on the slide, I think we can share that. It's already up. You can put up the slide so that we can follow. Good, thank you. The title of that keynote is Strengthening Health Systems through Supervised Pre-Service, Industrial Attachments, and Internship of Health Professionals. Why am I talking about health professionals? I don't want to talk about nutrition professionals for now, but I'll use a case of nutrition professionals to also enhance the component of other health professionals, also working in the sensitive areas of nutrition. And we know that we cannot lie, other professionals also touch matters of nutrition, either indirectly by allowing nutritionists to be in the space of operation, or by doing it when the nutritionist is not there. And it is something that we cannot say does not exist. So just by way of introduction, and I want to be very specific on what I communicate, because a lot has to do with the policy. I would want to say that when you talk of industrial attachment and internship, that is something we thought about in 2015, and it somehow stopped in 2021. And the reason was that you cannot put professionals on internship when they're not paid. But of course, it is still continuing at the pre-service as a concentrated component together with industrial attachment. So why strengthening health systems? And you know the language in Kenya, UHC is our big brother in the house. And many times you have heard that professionals of nutrition are complaining that they are not included in the UHC program. And if they are included, they are not given priority when it comes to decision making. And this is something that we have noted even with the unions. And we wanted to come as a strong team, and now that San is here, so that nutritionists can get their rightful position, even as they work with other cadres. Now, universal health coverage within the WHO definition framework implies access to key promotive, preventive, and curative, as well as rehabilitative interventions for all at an affordable cost. We all know this definition from WHO. I always tell people, WHO defines, but we adopt. So we adopt according to what we have as our capacity. It is not a rule. It is not a law. But it is a guideline that we can borrow from. So we say this definition does not clearly identify key areas of focus and may overlook quality aspects. And there are proxy determinants. I was saying that because when you're given a definition, there are certain components that are left out. And I was just remembering when Prof said that where is the community capacity? And it came to my mind that we instructed him sometimes back to do the capacity development framework for Kenya. He spearheaded that process, and I think he picked it from there. Now, we cannot overemphasize the importance of UHC in Kenya, and of course beyond Kenya, as a priority for WHO and other member states. And of course, given the current implementation focus, the emphasis is more on pooled prepaid healthcare financing system than on promotive quality healthcare. And you see the shift is more of who can pay and who is to pay for that person. But we're not looking at what to be paid from a broad perspective, because a lot of budget goes to the curative component. And because of that, we also know that it will be of a significant policy focus to explore key components of universal health coverage in the contextual technologies such as universal healthcare and universal health coverage. That was something that was thought about even before we had the SHA that is there. And so some scientists have argued that universal health coverage is linked to health systems reforms. And so if we want to reform the entire system of health, then we must bring in UHC as a component. I'm saying that because of the sector under which we are. However, it is essential now to note that UHC focuses on the provision of a range of healthcare services, now whose delivery would require adequate and competent healthcare worker. So my focus is on adequate and competent healthcare worker, both at the facility level and also at community level. And apparently, healthcare workers are drivers of health reforms and health systems. And they do this without a sound and competent driver. Even a powerful vehicle would not deliver maximum results. So if we are talking about healthcare delivery of service and we lack competent personnel, then we cannot be assured of access and adequacy of the service. And so repositioning current health care worker, particularly medical personnel, would meet the demand for UHC. And when you talk of medical personnel, we are not talking about a medical physician. We are talking about a nutritionist, a physician, a nurse. All the frontline team members are medical personnel. And these people must speak the same language. Now, from the nutrition lens, they must speak nutrition as a multidisciplinary team, because each one of them touches on nutrition, but being led by the professionals. So proper skills for such healthcare workers are likely significant gap across many cadres at pre-service training. And so it is understood that the pre-service training encompasses formal, theoretical, and of course basic training and practicum. And practicum is often implemented in two forms, that is industrial attachment and internship level. And in our caucus for CEOs of regulatory authorities, we have always talked about a supervised internship program and supervised industrial attachment programs. And we know that many health cadres in Kenya have internship programs, and this is determined from time to time. Now, the dilemma is whether such programs are adequately supervised the way we do. And if you are a medical professional in the house, don't be intimidated by the nutritionist, because we want to give you a case that you can follow from the KNDI's perspective. We can move to we are on the next slide. KNDI internship and legal framework. And I want to be very keen so that all our professionals can understand this very well. It doesn't become a point of argument. Now, the internship and industrial attachment framework is guided by the provisions of CAP 253B. That is the Nutritionist Act number 18 of 2007. and 7. We have asked nutritionists many times if they know the name or citation of the act, and 90% have failed. Today we are saying the act is cited as Nutritionist and Dietitians Act number 18 of 2007, which commenced to work in 2009 after the first gazettement of the council. Now, under section 6 D and G and section 13 BD, if you look at the table, there are operationalized sections of that act that deals with purely training of professionals. And so you will notice that, first of all, KNDI has been given the mandate to approve training institutions for purposes of training competent professionals. And in section 13 of the act, it provides for training of persons. And in this case, there is also preparation of syllabus or the core curricular guideline that needs to be used, and then developing regulations. So, Edna, if we were to get into the strengthening of nutrition service delivery, then having a policeman by your side alongside service would also be very important in advocacy and lobbying when it comes to county government. So the KNDI's industrial attachment and internship models are implemented in 2 phases, which I want you to take note of. The first phase, which is industrial attachment, is looking at the trainee at certificate, diploma, and degree level. And these 2 domains we have, in these 2 areas, we have 2 domains. We have the community level attachment, where students are placed in AGOs and EDNA and community programs. So we insist that all universities and colleges, they have to place them for 3 months in such community systems. And you see, nurturing them at that level would be very important. And then also we have those that go for clinical rotations, again for another 3 months, where they engage with health facilities. And during the standard term of the semester sessions and facility clinical attachment, we have what we call a concentrated practicum, which also run. And we expect that all these can give us up to equivalent of 960 hours. Now, we have the degree level also, where we also engage in post-graduation internship. That is the one I've said we stopped in 2022. And the reason for stopping it was because of non-payment of interns, though it is still running as a concentrated program. Next slide. Can we move to the next slide? Yes. So if we are looking at the industrial attachment and internship model, this is what we have. For purposes of understanding, on the industrial attachment arm, we have the community level attachment and we have health facility level attachment, which both takes 3 months. Now, in terms of semester and term level for training, we have weekly concentrated practicum at level equivalents of 4 to 7. What this means is that every institution must have 7 hours a week at health facility, level notwithstanding. So if they're diploma, they have to be in the clinics 7 hours every week from day 1 of their admission. And also if they're degree, the same. Now, when they have graduated, then we have a 12-month post-graduation internship purely for the degree. And that will go to different areas, community, we have the county, we have health facility and the food industry. And then they undertake professional examination. So the professionals that are accredited are those that have gone through our system. Next slide. So KNDI developed a training guideline, standard guideline for the universities and colleges in 2012. And this was to guide the training process. These standards are verifiable through checklists, which we have, that specifies all training requirements at all levels. And within the standard checklist, indicators related to students have been prescribed at the pre-service industrial attachment model, which is categorized into two. We had said the initial attachment places students within clinical health facilities accredited for that purpose. So we don't just send them, we send them to the accredited centers. And then the second attachment places students in community settings, which of course are NGOs, and these are those touching on matters of nutrition. In both cases, training institutions assume full responsibility for assessment. And that means we have signed MOUs again with all the centers and counties. This component will give us, as I said, 960 hours of practicum equivalent hands-on experience. And so when we combine that with the post-graduation for degree, students who graduated already had 2 years work experience, and we needed not to subject them to other experiences before they are employed. That was then. And I've also talked about the concentration. So I will skip the next slide and go to the industrial attachment implementation plan. Now, if you look at that table, which I call table 2, you will notice that at the certificate level, the total number of hours for hands-on practicum is 1,128. At diploma, we have 1,212. And then at degree level, we have 1,296. This is the minimum we expect from the professionals when they are accredited or licensed to practice on the basis of hands-on experience. We move to the next slide. Now, KNDI's model, and I call it KNDI's model because it is our own innovation, is guided by CAP 253B, internship guideline also developed by the council, which we initiated in 2015. The internship is a 1-year program. And 1 year means from January to December for a calendar year. And the model for the degree program is the one on focus because diploma, they only do professional exams. So we want to present for you the professionals we have in the country, which has not been adopted by any policy in the public service. And it is at the moment that now we are working towards that. So we have 6 areas of competency building for a degree holder professional. Next slide. If you look at that diagram, we thought as council, number 1, when this act was created, and it's the only one in the world, I want to say that with confidence, there's no any other act of parliament for any country. It's only Kenya. Even if you go to America, we only have American Dietetics Association, but we don't have a regulator unless news come. Now we asked ourselves, who is this creature called a nutritionist or a dietitian? And what we said is that if you were to do a BSc program in nutrition and dietetics, we would have 2 creatures at the end. One would be a nutritionist and another one would be a dietitian. We asked professionals to define who a nutritionist is. And people gave us different definitions. But we finally came to a conclusion that we have 2 creatures. One could be a nutritionist. The focus is on science. And another one could be a dietitian. The focus is on diet management. And so out of the nutritionist, we categorized 4. We had clinical nutritionist, basically working in the hospital facilities and clinical settings at community. The focus is on trials and also service delivery on matters of diagnosis and assessment. And then we had public health nutritionist. I had Edgar defining himself as a public health nutritionist by virtue of his practice, not by training. And we look at this at macro level. When I talk of macro, we want to see these people dissecting policies and analyzing them at national level and at county level. So their focus is on orientation of policies, which determine nutrition space in the country. And then we have the community nutritionist. These ones, they are at micro level. These are house to house. And the question I've always asked, when the Kenyan government was instituting the act that introduced community health promoters and gave them the responsibility to take charge of nutrition advice in the country, the question was, where did they train? And so our approach was to emphasize on the fact that government, both national and county, must, and I'm saying this from now the regulator's perspective, must have a mechanism of capacity building the community health promoters through community nutritionists. And so the counties must engage this creature at that level. So they are house-to-house creatures, and they can advise at that level of community. Then we had the food science nutrition, the nutritionist. The food industry has quite a lot for us. When you go to the supermarket, you see a lot of claims. Some of them are valid, some are not valid. Now, who checks the claims? We created food science nutritionist. And we said they don't just work in the food industry. They can also work in the hospital facilities. And the question was, who procures parenteral feeds, for example, and who scrutinizes that they are valid and have health integrity? If you go to a health facility now, this is a service that is offered by the nurse unit, the head nurse. And the pharmacists take charge because they think it is medicine when you are procuring parenteral feeds. But this is food. So who takes charge? It is the food scientist that can take control of that. Such creature is not in the health facility, but we are creating them. When you go to the value addition at community level, a product has been produced, or you want to translate a real food in the system to products that can be sustainable. We need value addition techniques at the community. These are food scientists. This creature is there, but it's still not doing the work. Now, on the dietetics side, we introduced two types of dietitians that is not there currently. One was a clinical dietitian. The focus here is on interpretation and formulation of diagnosis. And so these are the people who tell us how much somebody would require in a health facility. They have not touched the food, but they tell us we need this amount for this patient with this condition. After that, then they have to pass this to a food service diet therapist, who then manages the kitchen aspect. And this is where we went wrong with nutrition, because many hospitals thought that nutritionists are cooks, and so they have to be found in the kitchen. Now, we have a food service diet therapy whose work is to guide the menu process for the catharesis. And so when we were coming up with Regulation 48, we insisted that the nutritionist must be part of advisory for the kitchen in a health facility. And we also insisted that kitchen must be moved away from the mortuary, so that we can enjoy the food in hospital setting, which will meet our requirements. So we have produced these creatures with our target that we make nutrition service better, all the way from the field to the health facility. Next slide. Now, during the period between 2015 and 2021, the program was implemented with the help of internship unit here and faculty members and preceptors. And I want to talk about the three. at this unit of internship, this is purely administrative at KNDI. But when it comes to preceptors, we have those nutritionists that are already working in the health facilities that we have accredited and qualified as super trainers in the health facility. I'm saying so because not all of them can train. And we also have faculty members, those who are teaching our professionals at the universities. And these three come together to run this program so that they can train the professionals during the internship program. And they do comprehensive assessment. We did this by placing interns in 47 health facilities in the country. And every year we placed 500 nutrition graduates in health facility, which, if it was to be implemented well, we would expect impact in our health facilities when it comes to matters of food and nutrition. And the assessment program is rigorous. Unlike the medical professionals who are placed as interns and they are left to operate as service providers, these ones were intensively supervised so that we have hands-on supervision on site with the preceptors there. And how were they supervised? We had a faculty members assessment score where they go from time to time to check the progress of the students. And some of you, I know, participated in that. And we also had a weekly journal. Now, we expected them to keep all daily activities in a format that we prescribed per week, so that at the end of it all, they can give us an analysis of the key cases and episodes. And why cases? So that we would learn from the existing cases and come up with better areas to focus on in research and also in service delivery. And they were doing this for a period of at least 9 months. Now, in the next slide, we have talking about subspecialties of clinical nutrition and clinical dietetics, which were purely on level 4, implemented at level 4 and level 6 to level 6. So we insisted that clinical nutritionists and clinical dietitians are higher level competencies that would require inpatient service delivery. So we placed them there. And then for each, we had a supervising preceptor where we agreed on MOU. And these interns were supposed to keep logbooks, which we would remotely assess at the institute with the help of the faculty members. And there would also be a very clear and detailed master rotation plan for this nature of cadre. And so when they end their session, we would then give them professional exams to now qualify them. I think that was a very good idea up to that point, until where it stopped. Now, I want us to go to the next slide so that I can talk more there. The table where we have the so far trained professionals. You can move. Move again. We'll go back to the other slide there. Now, if you look at this table, it tells you clearly from 2015 or so, 2016 to 2021, we had placed it up to a total of about 8,000 professionals. And Edgar, these are professionals who are existing in the nation. Adding to the previous ones, making a total of 14,500. Now, out of these 14,500, in our records, only 20% are either working in the private sector or public sector, which means that we still have most of them hanging outside. And the reason why they're hanging is because the shift of health system is focusing on nutrition service without nutritionists. So there's a tendency of bringing in the nurses and other cadres to undertake nutrition service delivery. Now we are looking at, is it a good idea? That is a question that I would want this meeting to address. Is it a good idea? Now, we have put on board those that we need and we trust that would offer services to strengthen the nutrition service delivery. But they are still out of place. So the next thing is, how do you bring this group on board? Now go back to the food science wheel in the slide that you passed. Now, leave it there. Now, you've been seeing that KNDI, go back to the wheel. Stay on the wheel. We developed this wheel with a focus on food, science, nutrition, and that was to enhance the service delivery at food industry level. And we believed that every food company that is claiming nutrition in the context of public health must have a nutritionist. And that nutritionist is a food scientist. And so we came up with that model to strengthen the food industry. Now, if you go through the records, we have done up to 490 food companies on matters of nutrition. That was a market survey we did as per the audit. And they have 4,970 food products with the nutrition claim. And we only have the number that you have seen. We have not trained up to 40. Now, in as much as you are talking about malnutrition being eradicated in 5 years, that is a dream. That is a dream for me. Because we must therefore strengthen the human resource. And I was going to ask Professor and yourself, Edgar, the focus is more on budget allocation. Where is the focus on human resource? I heard from a sector where we were discussing about HRH, and we were told that nutrition work can be done by anybody. And most of those who are spearheading this process are actually the CSOs, Edgar. Because we battled with those who say we want an expert called nutrition nurse. So it has to be a very stern warning until they are to recognize that a nutritionist exists. But we also must recognize that nutritionists cannot have all managerial skills. But then we must absorb all these nutritionists. And the only route is through our collaboration. Can we also say that all the 400 dealing with nutrition and dietetics, can they absorb our professionals in the mix of other health cadres to strengthen nutrition? Your work would be easy at the community level and also at national level. Why am I saying this? If also the 5,000 plus health facilities in the country that are listed, each can have one nutritionist, they would have all these nutritionists absorbed. The problem is the health systems don't accept nutritionists. They don't acknowledge them from the DG going through to the top. And they would say, we don't really understand what nutritionists are supposed to do. That is not the case. They don't understand the framework of nutrition. And that is why from the word go, we are saying we have to now change the recognition pattern of nutritionists and dietitians to accept the current expertise that we have trained. And that starts with the public service. So my keynote was not an academic keynote, but to start the process and indicate why we are here. Other than the academics, we must also strengthen systems from the perspective of human resource for health. And we must give position for nutritionists to be heard. I remember when we were doing the pre-conference workshop, we were talking about a nutritionist being accepted to take a frontline lead on matters of nutrition where we have a consultant physician. And it was very clear that we have 1 unit weight. A nutritionist has equal weight as a consultant when it comes to frontline service delivery. If we have all these nutritionists properly trained and released, then we can start talking about reducing malnutrition. Hallelujah. I would want to stop there and open it up now for serious discussion. Thank you very much, Prof.
Let's clap for Dr. K. I know he has left it. Thank you very much. Part of our responsibility is properly advocate, and I think that is what Edgar said, for human resource for health, focusing on nutrition and dietitians, because we cannot spare our time, train these guys in the university, and then they get out, and then somebody wants to think that they want to do something that took somebody 4-5 years, and you want to do it without going to school? We will not allow you. That's why we have the law. That one, we will just bring the act and deal with you ruthlessly. And we have dealt with some of them. I want to thank those who have raised alarm. You no longer see Murugu. He saw fire. How many of you know Murugu? Yes, who was calling himself a nutritionist? Have you ever heard him being called nowadays? He saw fire. Fire. And where necessary, we will open fire because we have it. We have ammunitions. So based on that, ladies and gentlemen, and I'm very excited because of Edgar and the team, because these are the guys who employ and the over 400 the organizations that you have, and in Kenya 100 and in Kenya 423 organizations dealing in matters nutrition and scaling up nutrition. Edgar brought a mantra for those who are not here, that there is nothing for us without, and we will want to say that. Edgar, thank you for bringing there is nothing for nutritionists without nutritionists. That is the truth. And myself and Dr. K, we have dealt, recently we had a serious altercations with the cabinet secretary in his office. And we don't joke. And we told him, and cabinet secretary agreed with us. Because in the ministry, first and foremost, our section was reduced. I don't know, to a unit. Is it a unit? How can a director be under another director? And this I'm saying without fear of contradiction. How do you become a director under another director? At one point, the team that was there then, Edgar, had promoted nutrition to, I think we were a division. And we were pushing to become a whole directorate so that we have, and the Act specifies that. So we are asking, what has become of the Act, Cap 253B, that already established that component of directorate? We needed a director of nutrition. And for your information, the director has been appointed. But that director has been placed under another director, reducing our chances. They don't survive in that halfway house. That halfway house is so hostile. And myself and Dr. K have been there. We know how hostile it is. It's only that us, we return fire for fire. When you joke around, we return it properly. And they have recognized that. So nowadays, we don't even report down here. We deal directly with the cabinet secretary. And we are still advocating for this, and we want all of you, Edgar, whenever you will be talking to these guys, tell them that nutritionists are there in those numbers that have been presented. Dr. Keo and team did a requirement for nutritionists per population. And we realized that we are sort of how many? we need 60,000 nutritionists in Kenya. After that calculation, out of 60,000, people who have been trained and in school and everywhere, and the ones who are in service, are only 14,500. And then you still want to tell us that some of them cannot be employed? No, we are still less. So for us to be able to achieve that goal, and this I wanted our team from SAN, that among the things that you have to address in ensuring that we meet this goal by the year 2030 is human resource for health. Nutritionists we must see how to enhance these facilities, and we had given them a simple responsibility. If you are a hospital with 10 wards, then it means you need 10 nutritionists, clinical nutritionists in those. Each ward should have a nutritionist. You cannot give us one nutritionist for a whole facility and sometimes for a whole county. Then you're joking. How are you going to implement? How are you going to enhance this? Same to community in the universal health coverage. When they brought in the community health promoters, they did not initially bring in the component of nutrition, and they wanted us to accept. Again, as in our nature, returning fire for fire, we've dealt with them, and now I think we are moving somewhere where our colleagues at even the community level, we are going to have the nutritionists engaged at that point to be able to provide health services. So I think, Dr. K, I want to thank you because that is a component that has been a problem for us and continues to be a problem for us. On the internship, in our recent discussion with the Cabinet Secretary, and I think I will paraphrase the CS Duale. And by the way, CS Duale is a very good friend. He's a very good friend of ours. He's one of those best CSs. I hope he's coming here. You have invited him, Bonasio. CS Duale has said we are going to reintroduce internship and it will be paid. So we are going to post our interns through the ministry. CS Duale will post them. We hope he will be there even next year from January. We are going to post them and they will be paid. We have had, and I always call them, for lack of a better word, vinyangarika hawa chini, who did not want nutritionists to be paid. But we dealt with them properly. So I want nutritionists to be strong. You have a cadre that can be able to provide direction in terms of health in Kenya. And I'm talking on the jurisdiction of Kenya so that somebody does not tell Samia Suluhu and Uganda that we are inciting them. I'm just talking about Kenya, but we are ready to help East Africa if they want us. So for Kenya, Edgar, if this component is properly enhanced, we are going to have, and we will do our bit. For us, we will leverage on the other side of the rungu to make sure that nutritionists are placed where they are necessary. So next year, our nutritionists are back. And we have discussed this extensively with the ministry, and they're going to pay. For the ones who are not paid since 2015, Odero, where is Odero around? Our union. Odero will say something about it, but they have won a case. So they will be paid. I don't know. The case, they have won a case, they will be paid backwards. It has been signed. Eh? So they have, and Odero and team, thank you very much. Because Odero and team took up that role of the union. And you know, a profession is only strong for three main stones. Eh? Once you have a profession with a regulator, with ACT, a union, and then associations, that profession is a profession that will see the end of the day. Hakuna mtu atatuchezea. Wakicheza huko kwa welfare, Odero wako. Si ndio? Wakicheza huku pande hii yetu hii tunang'ang'ana nao na ACT. Peleka kotini, wakicheza, we win. By the way, all the cases, have we ever lost a case against them? But all the 40 cases plus, we have won all the cases. That means we are following the law to the, and then our association, the Speak Nutrition team and the other association you are doing, and the association that are under CSOs, we are doing a wonderful job and we encourage you to continue. So thank you very much. With that, I want to open for a few, maybe 2 questions on this matter. Okay, there. And by the way, nutritionists, we want you to be strong. Do your work. I would like to see somebody when our nutritionists who are in the ministry do a prescription and wacha mtu acheze na prescription yako tumuone. I know we have dealt with some and we have succeeded in dealing with them.
Yes, thank you so much for the presentation you have, Dr. Oke has done. My name is Arthur from Nakuru County. I'm one of the beneficiaries of what has been done in 2016, and I can utterly say it quite helped us in our career advancement. I work in a hospital, and I usually have other students always inquiring. I've been calling Martin and other teams where they can come for internship in as much, and I'm happy to hear it is back. I've seen the table, what Dr. Oke was presenting between 2016 up to 2021, and I was curious to noting in 2020 up to between 2019 to 2020, there was an influence of nutrition and all those. And in our hospital setting where we are having a lot of colleges that are mushrooming. And those particular colleges, yes, they are approved, but I think to us, the students that we are getting in hospitals, especially in those level 4, 5, and 6, in as much the curriculum has been supported, I don't know, for the lack of a better word, they take too long to be able to be packaged in a product. And we went further to check. I think we are having before us, there were a lot of good in terms of grades that to be able to become a nutritionist, you're able to having a B or a C and above. But right now we are having colleges and people are choosing nutrition profession due to lack of other courses because they are qualifying. What measures are we taking to be able to check that the grade that we are able to enroll nutritional students, that the packaged product, the final packaged product will be the best? Thank you.
Okay. Thank you. Dr. K will answer that. He has picked it up. Yeah, go ahead. Any other? Okay. Okay, Doctor.
Did you say that you are a professional or you were once a beneficiary of the internship? Maybe I need to get.
I was once a beneficiary of the internship.
Which county? And which hospital are you working now?
I'm working in Nakuru County Referral Hospital.
Also, it's the same hospital?
Yes.
Are you employed?
Yes.
Are you employed now?
Yes, I'm employed.
So the interns are being employed?
Yes, I'm the HOD.
Good. So that also answers some questions online.
Yes.
That the interns are being employed. Now, you are talking about the packaging, a product package to deliver service.
Yes.
And you are saying that they let me use a better term, they are half-baked. Is that the correct thing you are saying?
The entrance grades for them, I don't know if my other colleagues can able to echo.
What I want to ask from you is that the product that you receive in the facility, are they half-baked or they are fully baked?
Half-baked.
And you are saying that because of that, it could be probably due to the grades.
Yes.
Now, we did a study here and on grade entry. For the past 5 years, I think we've been doing that. And we discovered that those who scored E in mathematics, who later on scored 90, were able to perform better in competencies. And if you were here yesterday, when we started, we had a pre-conference symposium, which was talking about the competency building on the basis of portfolio assessment. And we brought on board that we don't necessarily need to use grades to assess a competency of a professional is about attitude and passion. And technical only takes 15%. 85% is about your passion and attitude. Now, we are coming up with a system where we don't just want to see somebody gets a first class and then they cannot deliver. We have people who have not scored first classes, and on their motor and competency, they have done well in service delivery. So it is not the grade. It is ruling out the fact that grade determines the competency of an individual. Correct? Edgar, I don't think you scored all first classes in all subjects. And I don't even think you are the first class in nutrition. Maybe you are not there, but you are now a better engineer when it comes to nutrition advocacy in the country. So it's about personality. So those who scored A's, are all of them competent in service delivery? Those in the hospital, you can tell us, 30, you get them, those who scored A's and went with clean grades. Are they also equally performing better? Not necessarily. So grade should be ruled out. Let us, the nutritionists, pick up the mantle of building competency to offer service. Grades notwithstanding.
Very important. And when we say grades notwithstanding, it doesn't mean that grades are not important. So let's not mix them. What we are saying is that the moment you reach the institution for training, our focus now focuses on competency building, which is basically the psychomotor, the cognitive, and the affective. Those of you who are teachers understand that last bit of it, the affective bit. So those three areas have to be tackled anytime when somebody is offering service. And for those engaged in training and who are not teachers like me, I had to go through a pedagogical training for 3 months in the university. I know all of us pure nutritionists are not trained teachers. Okay? But when you come to training in the university, we must retrain you. And those of you who manage, especially those individuals who got into teaching at the mid-level colleges, you remember one of our key standards is to take you back for another training for teaching so that you understand the affective bit. What affects our people in the hospital delivery and why you may perceive them as half-baked are around the affective bit. And some of them are just lacking confidence. Yeah. They run away. For example, I've been saying, I've just picked one component, just inserting a cannula or a catheter, for that matter, for delivery of partial parenteral nutrition. And I've been telling you, in the hospital, dextrose is not medicine. It's actually food. You know that? Yes. Normal saline. What is it? Isn't that not food? It's nutrients, isn't it? Now, why do you have to wait for somebody to come and help you out to deliver cannula? And yet this thing is being done by a certificate holder there, or even somebody who never went for training at all. When I was working with the United Nations in the South Sudan, I was in a place called up Chukudum. I don't know whether, just around Torit, for those of you who are familiar with the South Sudan. My friend, no professional would go there. It's too deep. So you have to train them to treat themselves, because in the next few minutes you do not know what is going to happen. So you go there, train them very quickly, and escape to Juba. You leave them and you will find they have done a good job. It took us just 1 week to make them know how to fix cannula, just in case somebody is suffering. And they are fixing, you will find, come back there. Now you reach, nutritionists are running away from the same work. And that is why there was this problem of nurse nutritionist until we stopped it. It happened a lot in the northern side. We had to put our foot down. There's nothing called nurse nutrition. You are a nurse or you are a nutritionist, full stop. And do you know why the nurse nutrition was coming? It's because certain competencies you are running away from, which you are not supposed to. And that is why we came up with a policy on cross-cadre competencies, so that we forestall those processes that make them feel like, some of them are just firefighting competencies. So what we are saying, please, when you are building your competency as a nutritionist, just make sure you know how to use even a sphygmomanometer. And this one now we have put in very seriously at the pre-training level. By the time a nutritionist comes out, the current team and even your team are better trained. That one I can assure you. That group from 2014 onwards, I know you are very competent, unless you're just mad, you don't want to perform. But anybody trained from 2014 onwards, these clinical competencies are not a problem. Okay? Just taking measurements was an issue for a nutritionist. They were not able to use sphygmomanometer, pulse oximeter, and these other tools. So that is what was making them not attractive to any employer, and especially in the clinical area. And even in the areas where we are dealing with those emergency centers, they want you to be an all-round, okay? They want you to be versatile. So when they realize that you're only going to talk about nutrition counseling and you will not pick up blood pressures, you will not pick up these other things, then they feel like, that's why the issue of nurse nutritionist was coming about. So what we are saying is that those basic skills, basic nursing nutrition skills is now with these guys. So I presume they should be competent. However, we are also having continuing professional development. For those of you who are in and you know you lack certain skills, especially, so one of the worst skills that I think we have in the profession that has affected us is the drug-nutrient interaction, isn't it? So that during the clinical area, instead of a nutritionist offering information during that joint ward round, they are running away or they are staying behind. Then they are seen as incompetent. It's just lack of confidence, isn't it? So with that, then I think it's not the grade, it's the competence, the psychomotor, the affective, and the cognitive put together. Thank you very much. Okay. Well, we have, I think, one question here. Both Sitati and bring it to Sitati and then Wahome.
Thank you very much, and good morning, everyone. My name is Agnes Sitati from Kenyatta National Hospital, and I'd like to appreciate Dr. for that very enlightening presentation, and also appreciate the conference coordinators for very thought out theme on the role of nutrition and dietetics in health systems strengthening. I think this theme is very timely and probably long overdue, that we really need to evaluate our role as nutritionists in the Kenyan system. And the reason why I am saying this is because as nutritionists, there's a lot that we are doing, even from the presentation that was made by Edgar. SUN has a membership of over 423. And I'm interested to know who are these members, because I'm not one of them. So, and how did you determine the membership? The membership on maybe just a personal basis, individual, organizations, who are these members and what are they doing? So it seems like there's so much we are doing, but we don't know what we are doing. So we honestly need to come together. And when we come together and put all our collaborative efforts together, then we shall be visible as nutritionists and dietitians in this country. Our role will be better understood by everyone in the health system. And like the issue of the intern. Okay, I also liked your presentation on the internship and attachment model, and it's a very important program. Even when we're talking about health, we as Kenyans really appreciate the role of the nutrition interns play, even just in while training, also supporting service delivery. There's a lot that they learn. There's a lot that we also want to share as health professionals to just help them to build their capacity, so that now when they enter into the professional workspace, they are well baked, not half baked, as you know, when they starting their internship program. So I think this program is very good. It's very timely, and to hear that next year the program will continue as planned. And a question that I have for Dr. Okeo is that maybe what role is KNDI playing in as far as ensuring that the government puts more focus and emphasis on promotive and preventive health, where nutrition plays a very key role. As you had rightly said, that the current focus of the universal health coverage is on curative. So what role is KNDI playing in ensuring that nutrition is given a lot of focus on its role in promotive and preventive health? And secondly, there's the issue of nutritional supplements and coverage under the social health SHA. That nutrition supplements are not regarded as important in medical treatment, yet there should be a differentiation between nutrition supplements that are taken for promotive and preventive health and nutrition supplements that are used for treatment of disease. Currently, nutrition supplements are only covered in inpatient, but you know that there are patients who are discharged and require these supplements to continue on the supplements out of the inpatient setting. So as healthcare professionals in the health facilities, we really don't know how to go about this issue, whether we should approach KNDI, we should approach the ministry, the Division of Nutrition and Dietetics, should we approach the union? Who should actually be on the forefront in addressing this very important issue?
The good thing is that Edgar is here. So, yeah, probably, yeah. Edgar, come see you address yours. Maybe, Edgar, just before, let me give Wahome first so that you can pick the questions. Wahome, yes, sir.
Thank you. Good morning, everybody. Mine is not really a question, but I'm following what I think Arthur was talking about. I remember at some point we lowered the entry criteria for nutritionists, both at the colleges and even at the university, at certificate, diploma, and even degree level. So maybe out of experience, and maybe to address some of the concerns that he has raised, and from my observation, one of the observations we've made is that you find students who really struggle because nutrition is not easy. Yeah, it's a tough science, let me tell you. So we have had some times to advise some of our students to change the course, because by the time they are in second year, they're actually failing like half the units per semester, and the university regulation says otherwise. Professor Nguka, you know what happens. So we have observed that from the academic side. And then I remember a particular semester where when students are coming at first year and some of them find they are not qualifying in some courses, then they are being sent to nutrition. There you can go and qualify, but they are not interested in the course. They come, if you're the one who is admitting them, because we usually make sure that we are at the desk to admit a student and tell them more about nutrition. They are not interested, but the entry criteria, of course, allows them to come. When they graduate and come to the clinical areas, I would expect, if I'm a good lecturer, have taken my students through the subjects very well, so that by the time they are coming, they have the competency, regardless maybe of the grade. If the student comes and they didn't have maybe that very good, maybe they had a C minus, they come, they work hard, they have the interest, they have the passion for nutrition. Probably they may not score very high grades at the university, but at the point by the time they are coming for attachment and internship, they could actually do even better than that student who had an A, from my own experience. But we have a problem there in terms of maybe performance, because we have to perform in the exams. We have a challenge there. Thank you.
Yeah, at exam level. But maybe, is there somebody from KMTC here? KMTC? We want to use an example which Dr. Keo will share with you. We are able to sort out a problem in KMTC around the issue of performance. Through Dr. Keo and his team here, there was a student in KMTC who was unable to pass exam completely, but who was actually disabled, had a Down syndrome. So we had to provide a solution as a regulator on how do we transit this student. And Dr. Keo talked about something called portfolio building as another way of assessment, so that an assessment should not just be one way. An assessment should have multiple approaches, so that the main intention of assessment is not necessarily to, block, but it's basically to expand people's ability to be able to perform duties they are supposed to, okay? So even the CBC now, the main intention of the CBC is to sort out that issue which we are talking about, so that when an individual is in your class and you're providing solution, then you must be able to find a way that they actually gain the competencies and not necessarily their entry criteria. So maybe going forward, I think what we'll propose, we have to retool our lecturers. We will have to retool our lecturers and everybody else who is in the training space. I think that is one of the things that's coming out to be able to deal with it.
Maybe just what Prof is talking about. You see, we say anybody who has been born can offer service. And this is a student with Down syndrome or abled differently, let me talk like that, being admitted and cannot pass through the motor. But the hospitals were reporting that was very good on hands-on. So do you want to reject that student on the basis of exam? So we had to bring Kenyatta University, the special needs department, KNDI and KMTC. And we agreed this student must pass and graduate and is now delivering service. Is that a crime? So don't look at academic A as a solution to humanity. Even what we can do by pushing a cat is important. So that's where we are going with the competency-based curriculum. You answer this because T is there.
T is there. So let me take 2 minutes to respond to some of the things that have come up. So number one, who are the members? So remember, I said this is an organization of organizations. Yeah. So for example, Kenyatta National Hospital will belong to the Sun Academy and Research. Yes, because I know you do some research in there. So you can see Dr. Zipporah Bukania to become a member of the Sun movement. However, within the civil society, we are exploring ways of having individuals. Yeah, because then right now it's just for organizations, but then we are seeing the need of having very specific individuals, not everybody. We'll be looking at a criteria of admitting an individual to become part of the movement. Yeah. So where are they? All of us, we are in all the 47 counties. So all our organizations are implementing in all the 47 counties. We also have got chapters. So the chapters are like counties. So they help us mobilize civil societies within counties to be able to implement. There are counties that say that they don't have partners, but when I give them the list, yeah, because the CSA, we've done a mobilization and documented who is doing what where in all the 47 counties. So you talk to me about Wajir, I'll tell you exactly the partners that are in Wajir. You talking to me about Nairobi, I'll tell you exactly the number and what they're doing, their addresses, and who is the point person in that. So just know your county, and I'll be able to talk to you about that. For the package that you're talking about for the SHA, it's a discussion that we've had, yeah, in terms of ensuring that those supplements are going to be included. So it's a discussion that is ongoing. Nothing much that I can report on, but I can tell you that it's a discussion that is ongoing. We are talking, we are having conversations with associations, we are having conversations with the ministry, we are having discussions with SHA themselves, so that this can actually be captured, because we know. Lastly, Daktari, for all these conversations that we're having, yes, a majority of them will be implementing based on goodwill. Yes. Remember, government communicates and prioritizes through policy. Yes. Are we a cadre? Are we? Let's look at the health policy, 2014 to 2030. Are we a cadre?
Yeah, and I want to be very honest. You know, Shitati asked, we are doing so much. It's like we are doing so much. That's a very important question. And it's like everybody is working on nutrition matters in the country, research, service, products, but we don't know who is doing what. We don't know what the NGOs, the CSOs that are in SAN have been doing. That is what is coming out. We don't know what the health facility nutritionists are doing. And that is why we are here today. That is why we brought Edna with all those 400 to come here at KNDI. We tell them what to do. And that is why the next move after the MOU is to push our SHA CEO, our friend, that the supplementation must be done with a lens of understanding, not what someone else think. And that has been done. So I got a letter from Nakuru. I don't know who wrote it. Okay. You the good. So, yes. I'm not going to allow you because I have your letter and the STH is ready. But I can assure you that we have picked up that with Mercy and we are going to address it. So we can join hands with the SAN and the dialogue that is going on so that that can be corrected. What is the role of KNDI in promoting, in health promotion? KNDI is now the best friend of the Office of the Cabinet Secretary and the State Department for Public Health. If you've been keen, you will realize that our PS has been going around talking about nutrition as a promotive tool, which means that they have adopted it. Now, a policy is being developed, which is going to give more weight to nutrition. I think it's spearheaded by the nutrition unit. It was just approved by the cabinet committee and it is coming up. Now we need you to input in that policy. That is when it will work. But we will provide that platform. So thank you very much. We are headed in the correct direction. More will come in the panel discussions. And of course, we have some other panel discussions and side events, so we can still ask more questions there. Thank you very much. It's time for us for tea. Laura?
So, ladies and gentlemen, we'll now take a short tea break. Please join us in the refreshment area just behind here, outside the conference hall. We'll reconvene at 11:30. Enjoy your break.
Please, ladies and gentlemen, even as you take your tea, we have exhibition booths the other side for Amref and Weetabix and others. You can pay a visit there. Okay, what do you want? Where? Which side do you want me to sit? Here. Mm. Okay.
Hi viewers, my name is Elizabeth and I'm here with my fellow rapporteur, Mr. Martin. Welcome today to our D2 conference. We started yesterday, we had an opening ceremony and today we are continuing on so well. So Mr. Martin, welcome so much. You can say hi to us.
Thank you, Madam Elizabeth, and good morning, our viewers. We welcome you to the day 2 of the conference, and so far we've had a number of presentations, and welcome to share on what has happened. Thank you.
So we've had a side event hosted by SAN, CSA, and ICASA, and the title was Breaking Barriers on How Gender Transformative Approaches Strengthen Nutrition Outcomes in Kenya's Health System. But we had just a scope of what SAN is doing, and the rest is coming after this break. Our second presentation was the first keynote speaker by Dr. David O'Kell, who is our chief editor, the CEO KNDI, and now this was a beautiful one. The title of the keynote was Strengthening the Health Systems Through Supervised Pre-Service Industrial Attachments and Internships for the Health Professionals. And this was a case study of Kenya Nutritionist and Dietitians Institute. So, Mr. Martin, what do you think were the key takeaways of this keynote address by the chief?
Thank you, Madam Elizabeth, for that question. And our viewers, the session has been very informative as we looked, and possibly maybe before I get to the key takeaways of the keynote address, it will still be important to just make a mention that as we had the side event by SAN CSA, we were able to appreciate and recognize the role that they are playing, and even how they have been able to capitalize on linkages and partnerships towards driving the agenda of nutrition in Kenya, within the region, and also globally. So it was a very informative and interactive session as we interacted with them. And it is our hope that we shall have more of this, even as we get to the panel discussions and even the exhibitions on what SAN CSA is doing within our country, regionally and globally. I would also want to possibly maybe say a few things that were key highlights of the keynote. And number one is that we cannot be able to have a UHC as a country. We know that that is one of the agendas that is being driven by our government. That is the bottom economic up transformation agenda. And the key thing coming out of it is that for UHC to work in our country, we need to have competent health workers. We need the people that are skilled enough, trained enough, and can be able to render that service to the patients and even to the general public as they visit our facilities. And then the other question that is also key or related to that is whether we are ready as a country to have adequate professionals that can actually render that service. I think at the end of the day, for us to move from voice to action, we have to have competent people and we have to have adequate professionals. So this is an opportunity even for us to introspect as a regulator and even as a service to ensure that we have trained sufficient numbers. As it is, KNDI has only licensed 14,500 professionals. I believe that for us to be able to have adequate professionals, we should be at around 60,000 trained health professionals. So I think there's still an opportunity for more to be trained and for us to be able to render that service. Then the other key thing that also was highlighted during the keynote was on the issue of professionals being trained and even that is at the pre-service level, being trained and supervised over their internship. And KNDI presented a very good framework on how to ensure that these students, once they get into the training, they can be able to leave the training period having acquired the necessary skills through the phase one, that is the attachments and the concentrated practicum, and then number two, the post-graduation internship. Thank you. Those are some of the key things that we can highlight.
Wow, that is so powerful. That is so powerful. So, Mr. Martin, I was so struck by the number of training hours that Dr. Kyo was emphasizing
Yeah.
on the attachment level and also on the internship level.
Yes.
Why do you think that? Why do you think such a high level training would be required for the nutrition profession?
Let me start by saying that nutrition and dietetics is is in the health sector. And when it comes to the human life, you cannot do piki ponki. You have to be sure that the person that is coming to train, to treat you, to manage you, has the necessary competence. So when you consider that, you realize that for us to have competent nutritionists, then we have to really ensure that at the pre-service level, they are exposed to an environment that allows them to build that skill. And when you look at the concentrated practicum, these students will now be able to at least visit medical facilities. I believe they will also be able to work with mannequins at the school level for purposes of maybe practicing and ensuring that by the time they are coming out of the training, they are well prepared to handle the patient. So the concentrated practicum and the high level of training is necessary for us to churn out qualified persons, so that we are not just in the business of churning, but also we are also churning people that can actually render a service.
Awesome. This makes a lot of sense. Yet, another thing that was highlighted in the keynote address was about the employment of nutritionists. So, at in the current state, we have actually about 20% of the nutritionists are employed. Why do you think there is such a big gap, and what can you say about that?
I may not be able to possibly maybe give all the reasons as to why maybe such a low number has yet to be employed. But I would want to possibly also throw the ball back to the nutritionists themselves. And I think as KNDI some time back gave an opportunity to even graduate the clinical nutritionists and dietitians. And they gave them a waiver for purposes of being licensed to get into private practice. So I think the notion that one has to be employed for them to work, I think is also something that we need to change. where an individual now trains, and if they do not end up being employed, they feel like they train for vain, or rather it is in vain. I think that is one of the mindsets that we need to change, so that as we are training and as students are getting to school, then they also get to realize that when they are conferred with those degrees and they are given the powers to read and to write, then they should also take up that opportunity. Be that as it may, we also have possibly to say that there is need for more advocacy and even maybe sensitization, so that the ratios are necessary within our medical facilities, that is especially the ones rendering clinical services, clinical nutrition, clinical dietetics, are staffed with the right numbers for us to be able to have even the same services. Maybe we also need to also sensitize hospital management teams and everything on the role and the critical role that nutritionists are playing, because they indeed play a very critical role. I think most of the cases that end up being adverse in the facilities would easily be managed if we have facilities staffed with the right number of nutritionists and dietitians. So I think that is just my take on it.
Thank you so
Yes.
much, Martin. That's such a good point. Sorry. So we also had different. Dr. Kyo mentioned in the speech that in the keynote address that we have different categorization of the professionals. So we had clinical nutritionist, public health nutritionist, community nutritionist. Can you maybe clarify and explain maybe to the audience or the person who is hearing this for the first time? Yes.
Thank you. I think in the earlier days when the act was just commencing, the registration and licensing was very broad. And for us at Register 10, the certificate was reading just nutritionist, dietitian, nutritionist, and dietitian. But then you realize that nutrition in itself is very broad, and dietetics is also very broad. And KNDI over the last few years has been able now to classify and categorize these persons, so that presently any graduate at BSc level can take any of the 6 pathways. And these are majorly categorized into 2. That is the nutritionist, where we have 4 categories, and then we have the dietetics, where we have now 2 categories. And I would want to start by talking about maybe the nutritionist. We have the clinical nutritionist, and clinical nutritionist principally deals with the science of food and its relationship to health. And when you look at the dietitian, on the other hand, that's a clinical dietitian, they interpret that science into meal plans, and they come up with meal plans, and they are able to come up with interventions for management of those conditions. Then we have the community nutrition and public health nutrition, again, 2 closely related professionals. The community nutritionist will work at the micro level, that is at the household level, work in terms of managing conditions. And the public health nutrition will work at the macro level, that is at the policy level, and be able to effectively lobby and advocate for purposes of nutrition policies at the county, at the national level, at the global level. Then we have the food science nutritionist. This is a nutritionist that works in the food industry. And I think we are far much from the days where people thought nutrition is about just the kitchen and cooking. We can be able to have nutritionists working with food industries for purposes of formulating products, be it they for just the normal household consumption for healthy persons, or be they the therapeutic product. Then lastly, we have a category of a dietitian that we call the food service dietherapist. These are dietherapy or a dietitian that has the normal competence in dietetics, but beyond that, possesses extra skills even in food service, food production. So this is a dietitian that effectively works even at the facility level, and works with the caterers to interpret what the dietitian has come up with into a presentable meal, so that at the bedside level, then the patient receives a palatable meal, nutritious and therapeutic enough to manage the condition that they're having. So in a nutshell, that is just a brief of the same. But for any that is interested in learning more about it, you can find our internship guidelines on the KNDI website, and they would help clarify further in terms of these categorizations. Thank you very much.
Wow, this is so elaborate, Mr. Martin. Thank you so much. So the nutrition field and the dietetics field is so wide, starting all the way from the community, the household level, going to the hospitals, all the way to hotels, food industries. This is nice. And it's a good thing. So it means as a country, as also the world, we are sorted when it comes to nutrition and service delivery. So, and by the way, there was a phrase that has been used so much in those presentations. So, like, nothing for us without us. What does it mean?
Possibly maybe how I got it is that as a nutritionist and possibly even as the general population, we have a duty to ourselves and to ensure that everything eventually maybe works for us. If we are to have everything working, if we are to have maybe nutrition delivering, it has to work for me and for it to work for us. But possibly maybe as we continue, we'll be able to invite the speaker, especially who alluded to that first statement the very first time, also joining us and sharing and elaborating further on the same. And possibly maybe as also a participant, you can also add a few things of the same.
Definitely, that's okay. That's very great. We would like also to have our speaker, Mr. Edgar for the Sun, and also our CEO should also be able to in a position to explain all this. So again, our viewers, this has been a power-filled session, and we are grateful that you are connecting and you are still following. But if you still want to come physical, it is not yet closed up. So our conference is going to be running up to Friday, and you are all welcome. It's going to be a power-filled session, a very enlightening session, and a very beautiful time for you to connect and to learn more. Thank you so much. Stay tuned for more. Bye-bye.
Thank you. Enjoy.